Yep.
Hi, Mr. Ken.
Yes.
Dr. Licata. Nice to meet you.
Nice to meet you.
We'll be doing the neurological exam today. So we're going to be looking at your thoughts and your cerebellar function. We're going to look at all kinds of nerves and reflexes and strength. Any questions before we start?
No.
Well, good to have you today. Thank you. First thing, some of these questions will be a little odd. Hopefully they're very easy for you. But can you state your name?
My name is Ken Armstrong.
Okay. And can you tell me where you are?
I'm in your office.
Excellent. And what date is it?
Today is August 20th.
Good job.
Thursday.
Good job. I have to check my watch myself. Good job. And what building is this?
This is Neomed.
Excellent. That's all I need to know. And so, can you say the phrase, Mary had a little lamb?
Mary had a little lamb.
Excellent. In the past 2 weeks, how would you describe your overall mood?
Fine, pleasant.
Okay. Nothing special? Even
Yeah,
keel?
even, yeah.
Okay. I'm going to give you 3 objects to remember, and I'll ask you them later in the interview. They are apple, table, and penny.
Mhm.
Can you repeat those back to me?
Apple, table, penny.
Excellent. That's all I need for now. And in about 5 minutes, I'll ask you to repeat those. Those are the tests that we use for cerebral assessment. The structure behind this exam is going rostral caudal through the brain. So we're doing cerebrum, cerebellum, brainstem, pons medulla, which are basically the cranial nerves, spinal nerves, which are generally the reflexes and sensation, and then finally peripheral nerves. Actually, I'm sorry, spinal nerves are reflexes and peripheral nerve sensation. So we're going to move on to the cerebellum. So if I can ask you to put your hands up and down on your knees as rapidly as you can. And you'll notice Mr. Ken has a slight asymmetry, but that's not unusual on the non-dominant hand to be a little bit slower. And he's certainly within that realm. I would also like you to tap your fingers together as quickly as you can. I'm looking right at his nose, and I'm kind of looking at my peripheral vision to see if one is much slower or clumsier. They're exactly the same speed, and he has good skill there. I'm going to ask you to tap my hand quickly as you can. This is awkward unless you're a dancer, right? But that's good. That's good speed for rapid alternating movements. I'm also going to ask you to touch my finger with your right hand and then your nose. And then I'm going to move the target. I'm going to try and have him extend as far as he can. Very good. You want that elbow to be fully extended, so this isn't a very good test. You want to make sure he's reaching. And on the left, same. Good. And what I'm looking for, he almost demonstrated, was this kind of emotion in the middle or going past the finger. Move on to heel to shin. Now, you can hide a lot on this maneuver. If I ask him to put this heel on this shin and go up and down, he might be in bad shape, and using the shin as a guide, he'd still be okay. So I'm going to ask him instead to keep the heel 1 inch over the shin and go up and down. I'm not using a ruler, don't worry. But just roughly, I'm not seeing any clumsiness or anything else. But you can see how somebody could use their shin as a guide and they'd be all over the place. Like, well, yeah, I guess they could do it. And obviously the other way as well. 1 inch over. Good, very good. Good and steady. You saw how he didn't have any tremors with that either. And that's basically it for the cerebellar testing. Just one other pearl. The vermis of the cerebellum is often affected in chronic alcoholics, and in that case you'll see truncal ataxia, and so his trunk wouldn't be able to sit still. He'd be not steady. We usually don't see that very often. Next, we're going to check cranial nerves. So I'm going to ask you to plug one nostril and tell me what you smell. Nothing too unpleasant.
Coffee.
Yes. And the other side?
More coffee.
Yes, good. We always need more coffee. The point is, it doesn't matter that he can name the smell, it's just that he senses something. And different people have different abilities to name what they're smelling. That's not what we're testing, it's just that they sense something. You don't want to use something noxious like alcohol for this test because you're creating a different stimulus. You're not actually testing smell with that. I'm going to check visual fields. So what I'm going to do is close this eye. Good. And I'm going to hold up the fingers halfway between, and I'm going to ask you Which set of fingers moves? Keep
Moves.
looking right here. Tell me which ones. Good. Good. Both. This way. Good. Good. Switch. And do this again. Good. Good. Sorry. Good. Good. Very quick test of the quadrants of the visual field, and that goes very quickly. We're going to use the pocket screener, which is also in the neuro exam drawer. And I'm not going to make a production of this, but I carefully check the distance at which this is supposed to be tested. Most of your cards are at 6 feet, which is an arm span, but this card says 14 inches. I'm a fisherman, so I know that's about 14 inches. And so, Mr. Ken, can you read the numbers on the lowest line that you can read?
428739.
Very good. And cover one eye. Read the same line backward.
937824.
Very good. Flip eyes. Read them forward once again.
I cannot. I would have to read the line above.
Okay, go ahead.
937826.
Excellent. Thank you. We are going to check for symmetry of the lid position. Remember that cranial nerve 7 pulls the lid down. And so if he's unable to close the eye, it's probably a cranial nerve 7 problem. Cranial nerve 3, the Roman numeral 3, are pillars that hold the eye up. And so if that's weak, you'll have a ptosis of the lid. And that's a visual exam. We're going to check pupillary size. And so I'll ask him to look at my nose. I'll shine the light from the side. Watch that pupil contract, flash across the other one. This should be done in a dark room. For the sake of filming, we're doing it this way. Backward, constriction with a direct response, and I flash across just to check the size. We're going to check the accommodation and near reaction with the extraocular motions. So here we go. Follow my finger without moving your head. You try to get them out almost to the extremes. As he comes in for the near target, I'm testing convergence, but I also notice that the pupils constrict. That's accommodation. We're going to check cranial nerve 5. I'd ask you to bite down for me. I'm feeling the masseter muscles, and those are good functioning and strong. I'm also going to check sensation, sharp, dull, by fracturing a tongue depressor, and you want to do this lengthwise. This isn't a Western movie where you're breaking a beer bottle for the big fight scene. So you just want to have a sharp corner and a dull corner. You don't break them like this with all the jagged splinters. So I'm going to be checking sharp and dull sensation on the face. This will be sharp. This will be dull. I'll check on your forearm.
Sharp.
Good.
Dull.
And I'll be more gentle on your face. So tell me what you feel.
Dull.
Good.
Sharp.
Good.
Dull.
Good.
Sharp.
Good.
Dull. Sharp.
Okay. Good. We're also going to check light touch over these areas. Remember the 3 branches to the trigeminal nerve, mandibular, maxillary, and ophthalmic. And so tell me which side you feel a light touch on.
Left.
Good.
Both.
Good.
Left. Right.
Good. We're going to check the cranial nerve 7 because we already checked for 3, 4, and 6 with the eye movement. Cranial nerve 7, can you raise your eyebrows? Close your eyelids tightly. I'm going to try and open them. Good. Puff your cheeks and smile. Good job, frown. Good job. Good job. And we're looking for symmetry there. Next, we'll move on to cranial nerve 8. I haven't noticed any hearing deficits. However, we typically check higher frequencies for hearing loss, and it's actually well mimicked by rubbing fingers. So I'm going to ask Mr. Ken if you can close your eyes. Tell me which side you hear the finger rub on.
Right.
Good.
Both.
Good.
Left.
Good. Excellent. There are hearing tests that we can check. I'm going to test the Weber and Rene test using a 512, the smaller tuning fork. This is a higher frequency. In order to activate the tuning fork, my uncle was a piano tuner and he would always hit it on his head. So it's a genetic thing. I'm going to ask, does that sound louder on one side or another?
No.
Good. People often get that quizzical look when you ask them that question. I'm going to turn this around a little bit for the sake of you learning well. But first, let's show you the Rene test. And that's a test of air conduction versus bone conduction. Air conduction should be better than bone conduction. So I'm going to press this over his mastoid. Can you hear that?
A little.
Okay, tell me when it goes away.
Gone.
Okay, do you hear that?
Oh, yeah.
Okay, so air conduction is greater than bone conduction. How are you going to remember this? The easiest way is to create a lesion. Let's say Mr. Ken is going to have a conduction lesion. I'm going to ask him to put his index finger over his ear flap, his tragus. Okay, now let's do all this testing. Which side is loudest?
Oh, right.
Much different, right?
Oh,
now, when it's asymmetrical, it's either because there's a conductive loss on this side, duh, or a sensory neural loss on this side. Let's continue with the testing. Tell me when that goes away. Do you hear it?
Mm-hmm.
Okay.
Gone.
Do you hear it now?
Mm-mm.
Right? Why? Because your finger's in your ear, because you have a conductive hearing loss. So the point is, that's an example of a conductive hearing loss. If you do this on yourself, you'll remember this forever. But you can simulate a conductive hearing loss and you'll remember that it lateralizes on the Weber test and bone conduction is greater than air, in this case with a conductive hearing loss. So if you have that example, the other alternative is sensory neural. But at least you understand why that works that way. I'm going to check cranial nerves 9 and 10. Cranial nerves 9 and 10 cannot be separated. There is one little nugget of information. That is, if you've ever noticed when you use a Q-tip that you cough, it's because cranial nerve 10 is sensory to the ear canal. And so when you put the Q-tip in, you feel like you're going to cough. And that's actually a unique function of cranial nerve 10. So we're going to have him open the mouth and say, ah, and he has a nice midline uvula. We could check the gag by touching the palate, and the uvula would deviate toward the side touch. That's your tensor veli palatini muscle. And we're going to have him swallow, and that's 10. And now we'll check 11 with the shoulder shrug. Good, or face against my hand. Good, the rotation there is cranial nerve 11. And cranial nerve 12, if you will first make an observation with the mouth open of the tongue, we're looking for any fasciculations on one side, which is usually a sign of denervation, but I don't see that. Can you put the tongue to the left and to the right? Now, we're going to move on to the reflexes after we check for the recall of those 3 objects that I gave you. Do you remember any of those, Mr. Ken?
Apple, table, penny.
Holy cow, that was perfect. Good memory. That's excellent. We're going to move on to reflexes. Patient will sit as if he's holding his favorite beverage on his knee. Good job, nice and relaxed. And this will be a little hard to see, but I use my middle finger and I go all the way across the antecubital fossa and bend the tip just a little bit, and I will hit, and that's a nice reflex there. Also, for the brachioradialis, that's C5-6. This is also C5-6. I come over the top just a little bit, and once again, I get a good reflex there. Triceps reflex, probably the hardest reflex. I'm going to, in a minute, lift this higher, but for now, you come behind the olecranon, the point of the elbow, and posterior, there's a little hole. That's exactly where I'm going to aim with the point of the hammer, and there's the reflex. On the lower extremities, L4-5, the patellar reflex, I'm going to do a forehand motion. The hammer swings. None of this business. You need the speed of the swinging hammer at the end, the acceleration, to get a good reflex. And I'm coming to this side, so I can do a forehand on this side, lifting up slightly on the foot. If I leave it slack, I won't get a reflex because I'm not getting a stretch. I have to put a little tension. I can lift the foot up, and I feel the step on the gas, with the reflex. And once again, there's that reflex. I'm going to check Babinski on this side, and of course I check it on the other. I like to use my thumbnail. I scrape along the area that would be the footprint, and I don't see anything. I scrape along the pigmented portion of the sole, not over the arch. Positive, the toe would come upward and the toes would spread outward. This is normal in babies up to 1 year of age because they're not fully myelinated. The last check on lower extremities is for clonus, which is a test of increased tone. You lull them into a sense of false security by being nice and gentle, and then you snap the foot upward. This won't work. You really have to get them nice and loose and snap the foot upward, and you're feeling for beats of clonus, usually seen with increased tone. None of that today for Mr. Campbell. We're going to check for motor strength and tone. Muscle strength is graded on a 5-point scale, which is shown in your handout. So in the upper extremities, we're going to check passive tone by grabbing the elbow and telling him to go very loose, and there's no increased tone. If I really had to, force my way in, that would be an example of increased tone. You check on both sides. Increased tone typically happens after an upper motor neuron lesion. He's nice and loose. This is normal tone and relaxed. Same on the lower extremities, and he doesn't have any increase in tone, upper or lower. On the upper extremities, we're going to check for strength. So I'm going to have you put your wings up. Fight me. Good. Fight me. Good. Arms out front. Lift me. Push me. Good. 2-finger grip, hard as you can. Hard as you can. Good job. Fingers apart. Good. Fight me. Good. Make a ring. Fight me. Very good. And bring your fingers together. And in fact, sometimes I'll test this by having the patient grip my ID badge, and no help from the thumb now. Let's keep this fair. And pull. Yes, I finally won one. Good job. We're going to have you lift the knee. Fight me. Good. Fight me. Good. Pull me down. Good. Same on this side. That's right. There you go. Good. Push out. Pull back. Good job. Lift the big toe. Good job. Push your feet out. There you go. Good job. Okay. Lower extremity and upper extremity are intact. We're going to use light touch. For now, I'm going to use the back of my finger, and I'm going to say, does this feel the same on both sides?
Yes.
Same or different?
Same.
Good. Same or different?
Same.
Good. And we're going to check the lower extremities. Same or different?
Same.
Good. Same or different?
Same.
Good. Same or different?
Yep. Different.
Good. Very good.
Same.
Good. Couldn't fool you. We're going now, after comparing side to side, we're going to compare distal to proximal. Does this feel the same as this?
Yeah.
Okay. Does this feel the same as this?
Yes.
Okay. And does this feel the same as this?
Yes.
And does this feel the same as this?
No.
Good. We would also perform this on the trunk over the abdomen. There we go. So does this feel the same as this?
Yes.
Does this feel the same as this?
Yes.
Does this feel the same as this?
No.
Good. And we're going to do sharp and dull. Going through tongue depressors like they're going out of style. Once again, I'll demonstrate how to break the tongue depressors. Lengthwise. Does, let's see, sharp or dull?
Sharp.
Good.
Dull.
Good.
Sharp. Sharp. Sorry.
Oh, you're okay.
Dull.
Good.
Dull.
Okay. And on the lower extremities, and you have to make sure the patient has his eyes closed while you do this.
Sharp.
Good.
Dull. Sharp. Dull. Sharp.
Good.
Dull.
Good. We will next check vibrational sense. Realize that the larger tuning fork is tuned to the frequency of the Pacinian corpuscle, the one with the reindeer horns on it. This is a very low frequency. You can feel it vibrating, again, because that's your Pacinian corpuscle sensor in your skin. So I'm going to use the distalmost bone I can find, typically the thumb. Say, tell me when that stops.
Gone.
Okay, and I'm the self-control. Same on the foot, although I'm not going to take my shoes and socks off. I'm going to check over the distalmost bone I can find and wait for the vibration sense to go away. This would be repeated on both sides.
Gone.
Okay. Typically, you can still feel a slight amount of vibration even when the foot is not able to sense it. So I allow for a little bit of difference. You can try this on yourself without your shoe, which I've done, and I find that my toe is not as sensitive as my finger. But basically, you're using yourself as a control. We're going to check proprioception, and so we're going to take a digit. Watch closely. I'm holding this from the side of the finger with 2 fingers. Now I'm using 2 fingers here and moving the distal phalanx up or down. And I'm going to ask Mr. Ken, this is up, this is down. Tell me which direction I move your finger, please.
Up, up, down, up, down.
And repeat on the other side. Again, 2 fingers holding the edges of the distal interphalangeal joint, and the other 2 at the phalanx. This is up, this is down. Tell me which way.
Down.
Good.
Down.
Good.
Up, down, up.
Good. You can do the same with the toe. Again, 2 fingers laterally. If you don't do it this way, he'll sense the up and down of your fingers on the nail. You need to hold it by the edges in both places, over the distal joint and over the distal phalanx. So down, up. Tell me which way.
Up, down, up, up, down.
Good. Same on this side. This is up, this is down. Tell me which way.
Down, up, down, up.
Good. Graphesthesia is the ability to recognize a number or a letter written on the skin. And so I'm going to write a number. Please tell me what the number is.
3.
Very good. We can check 2-point discrimination with a paper clip, but the distances that are normal vary everywhere. Obviously on a fingertip, a very sensitive structure, it'll pick up very small distances, but over the back, it might be as far away as a centimeter. We're going to check gait, and for that we'll move into the hallway. There we go. Just go ahead and walk to the computer and back. There we go. Very smooth turnaround, equal weight on both sides, equal timing. Can you walk in a straight line along the tile lines? 1 foot in front of the other, balancing. Very good. Good thing I'm not a policeman.
Yeah.
Okay, very good. Are you able to walk back on your tiptoes?
Like this.
Yep. Very good. You don't have to walk back on the line this way. And can you walk on your heels away? Very, very good. Come on back in, and I'm going to show you a positive for the video. So I have a positive foot drop on my left, and so I can maintain my right foot off the ground when I'm walking, but I can't maintain the left foot because I have an L5 injury at the disc. It doesn't hurt or anything, but that's what you might look for. We're going to do the Romberg test, so if you don't mind standing on the platform, I'm going to have you feet together, arms out front, and you'll notice that he keeps his balance very nicely in position. This is not the Romberg test until he closes his eyes and we remove the visual input. I wouldn't ordinarily do this on the table, but I know Mr. Ken is normal. I would ordinarily be ready to catch him. But this is a Romberg test and he passes marvelously. While you're here, I'm going to have you put your arms palm up. We're going to check for pronate or drift. And we're going to have him close his eyes and stand still. And he keeps them absolutely in the same place. After a stroke involving the corticospinal tract, one of the hands on the affected side will drop and pronate without the patient knowing. So it's slower than that. It's very, very slow. So you need to wait about 15, 20 seconds. But that is the pronator drift. We also need to assess meningeal signs, and meningeal signs happen in meningitis. Typically, people will have trouble flexing their neck. So if I can ask you to touch your chin to your chest, He's obviously doing fine with that. There are two classic physical exam tests for this, though. The first, I'm going to have you lie back, is Brudzinski sign, and that means if I flex the head forward manually, this is a normal exam, but what might happen is when I flex the neck, he will flex his knees briefly. And there's some other signs that can come along with this, but suffice it to say, you lift on the neck, the knees flex. The other one that I think is actually very clinically useful even today is Koenig sign. Koenig sign, you're going to flex the hip to 90 degrees, and now you're going to try to extend, and he gets it nice and straight. A positive would be that it stops at 45 degrees. And I might be able to overcome it or muscle it, but this is a positive Koenig sign. You say, well, who cares? Why do you do both? Koenig sign was described by, guess what, by Koenig, who took care of coal miners' children, and many of them had tuberculous meningitis without inflammation. This sign is very useful in immunocompromised patients who might have a fungal meningitis or something less inflammatory. Even when Brudzinski is normal, this can be positive. So that's the utility of that. We end with the fundoscopic exam, and if I could have you sit on the edge of the bed. Very good. I'm just going to perform this on one side for the sake of the video. Hand on shoulder, spot on cheek. Find the spot. Lock in your thumb knuckle into your cheek. Don't touch the top of the scope. I'm going to come up to his pupil. It'll turn red with the red reflex, and I'm going to corkscrew in. So I'm coming in almost horizontally, and that allows me to get close enough to the eye to see what I need to see. It's the end of the neuro exam. I'll sanitize after shaking Mr. Penn's hand. Thank you, Mr. Kemp.
Thank you.
Normal neuro exam.